Hello, everybody. My name is Lara Orlandic. I'm a researcher at the Embedded Systems Laboratory of EPFL, and I'm going to tell you about the Coughvid crowdsourcing dataset. So what do we know so far about COVID-19? As we've heard from previous talks, we know that one of the best ways to tackle the pandemic is through massive widespread testing, which is essential for contact tracing and isolating infected individuals. We also know that one of the most common symptoms is a dry cough. And as we've heard in many previous talks, that automatic cough sound classification has been successfully done to diagnose a variety of respiratory conditions. And it can be deployed on something as simple as a smartphone, so it can provide rapid, scalable, and inexpensive testing. So one of the main goals would be to train machine learning models for COVID-19 screening based on cough sounds. But anybody who works on machine learning knows that you need lots of data for this. So another goal would be to provide a diverse labeled cough sound data set for things that go beyond just COVID-19 classification, but also classifying other features of coughs as well. So which databases exist to perform this task? There's the Google Audio Set, which consists of about 900 coughs that aren't labeled, so you don't know if somebody's coughing because they're clearing their throat or if they have COPD. And this is before COVID, so there are no COVID coughs. Next, there's the IIT dataset, which goes a step further and takes hospital validated data. So you take people who have been diagnosed with certain conditions and they label whether or not they have dry coughs or wet coughs. But this is also pre-COVID and there are only 30 subjects. Then there's an interesting one that's new called the No Coco Da, where they take media interviews of COVID-19 patients and basically cut 73 cough sounds from those interviews, which is great because you have COVID positive subjects, but there's only 10 of them, so it's not really enough to perform generalization to the global population. Finally, there's the Kaswara project, where they crowdsourced over 1,000 cough samples and then manually annotated them to see which ones actually contain cough sounds, which is a great start, but we really need a more extensive, labeled, and expert-validated cough sound database. This is where Coughvid comes in. So we've gathered a crowdsourced cough recording database of over 20,000 cough sounds. 1,000 of these claim to be COVID positive. I say claim to because it's crowdsourcing. We don't have any medical validation. And we also developed and open source a cough detection model, so an easy way to determine whether or not a recording actually contains a cough sound or not. Then we were assisted by a team of doctors who took our stratified sample of our 20,000 cough sound recordings. So depending on the label that the users provided of COVID-19, symptomatic, no label, or healthy, we took a balanced sample of those and sent them to some experts to listen to and figure out whether they had a COVID-19, another condition, and then they really analyzed them thoroughly to determine more medical features of these coughs. Then we did some internal validation to make sure the database was consistent, so that it represented lots of different demographics, and that the data labeled as COVID-19 actually came from countries where they had high positivity rates at the time. And finally, we wanted to make sure that the expert labels were consistent both with each other and with current medical knowledge of the condition. So how did we collect all this data? We started in April through September, so when the disease was prevalent around the world. And we created a really simple web interface where all users had to do was click the record button and it would record 10 seconds of coughing and upload it to our server. Then users had the option of submitting metadata, so age, gender, whether or not they have previous respiratory conditions, and whether or not they had been diagnosed with COVID-19 or had symptoms. So the data is fully anonymous, and we blurred the GPS to 1 decimal place, so that represents about an 11-kilometer radius, so it's impossible to trace people from this data. We also provided safe coughing instructions because coughing is one of the best ways to spread the virus, so we instructed people to cough into their elbows and keep their phone at arm's length away. This also helps with data quality because when people cough directly into the phone, it causes the sound to clip, so provides better sound quality. Now, a common pitfall you all may have realized from crowdsourcing is that sometimes people don't take it quite as seriously as they should, and we got a lot of recordings of silence, people talking, or television noises, so we needed a quick way to delete these from our data sets. That's when we trained a machine learning model to identify which recordings contain cough sounds and which ones don't. So first we pre-processed the coughs through low-pass filtering and extracted 68 audio features. These features are both time domain, frequency domain, and they have been previously implemented for cough classification and cough detection models. Then we trained an extreme gradient boosting classifier on our hand-selected data set of about 200 coughs and non-coughs. Then we can see from the AOC that it has an area under the curve of about 0.97, so quite good. It works decently well in our testing sets. And then there's always the trade-off of where to set the decision threshold. So do you set a high threshold and clean a lot of your true positives, or do you set a low threshold and you keep a lot of the non-coughs and label them as coughs? We leave this up to the users of the database. So we append the cough detected probabilities, so the outputs of the ML classifier, as metadata of each sample. So then users of the database can set whichever threshold they want. For example, we set 0.8, which you can see from the curve, keeps 80% of the true positives, but less than 10% of the false positives. Then all of our code is open source. You can access it here at our C4Science Git repository. And that way, if for some reason you're unable to open source your own cough databases for privacy or what have you, then you can keep the same pre-processing steps and cough detection model. So we are not doctors. We could not tell a wet cough from a dry cough just by listening to it, and we didn't know what a COVID cough sounded like. So we were fortunate enough to be helped by 3 expert pulmonologists who listened to over 2,000 cough recordings. And they gave us lots of different information, like whether the cough was wet or dry, whether you could hear medical anomalies like wheezing, dyspnea, choking. Then they would diagnose each cough. They would say whether it's an upper or lower respiratory infection, COVID-19, COPD, etc. Then they would assess the cough severity. And we kept 150 coughs annotated by all of the experts so that we could assess the degree of overlap between the ratings. So a good feature of any extensive data set is that all demographic groups are represented. So let's take a look at our metadata distributions. So we can see we got more males than females for some reason, but we have so much data that you can easily just do stratified sampling. We have many more people without previous respiratory conditions, which is reflective of the global population. Most people were healthy, but we do have a significant portion of COVID-19 and symptomatic labeled data. Then the age distribution was about 34 years plus or minus 13, which is a bit younger than the general populace. But if you think about our target demographic for an app-based solution, it would be more younger people who tend to use these kinds of digital tools and people with mild symptoms, because people with very severe shortage of breath and coughing may want to go to the hospital to get tested and not use an app. Next, we wanted to make sure that the cough samples labeled as COVID-19 actually came from countries where the disease was prevalent at the time. And we know from our studies show that COVID-19 coughs can persist between 2 and 3 weeks after a positive PCR test. So what we did was we took the timestamp of each recording, find the GPS location for the ones that provided GPS, find which country the recording came from, and then added up all of the new COVID-19 cases in the previous 14 days up to recording. Then we found that over 90% of both the COVID-19 and symptomatic recordings came from countries with more than 20 new cases per million population, which is quite a bit considering that most of them came from April and May when testing wasn't as widespread. Then our recordings come from over 100 different countries, so we really have global representation within our data. So here's the visualization of all of the recordings we received in April and May that came from COVID-19 labeled and symptomatic labeled subjects. And then each country is color-coded based on its COVID incidence rate in these 2 months. So we can see that most of our data came from Europe and the United States, where the disease was running rampant at the time, and also Turkey. So quite a good representation. Next, we wanted to make sure that the experts more or less agreed with each other on their diagnoses. So we can see a fair agreement on the medical anomaly detection, such as wheezing, dyspnea, stridor, etc. but there was a poor agreement on the COVID-19 diagnosis. So a lot of the experts would confuse COVID-19 with an upper or lower respiratory infection. There was also not so much overlap between the self-reported COVID-19 status and the expert-labeled one, so these were almost entirely uncorrelated. But this may reflect negatively on the data set, but it really reflects the reality that COVID-19 is a new condition and people don't learn about it in medical school yet, and it has symptomology similar to both upper and lower respiratory infections. One commonality between the COVID-19 labeled data from the doctors was that they were mostly dry, so that makes sense because we know that's a common symptom. They didn't have any other health anomalies, and they were mostly mild. So this is good, but the gold standard would be to have confirmed COVID-19 positive coughs from either a testing center, a hotline, or a hospital. So let's say that everybody who listens to this talk goes home and uses the Coughvid dataset to train a machine learning model. How do we know which one's the best? So this is why we kept a private testing set that we withheld from publishing. And each sample is at least annotated by one expert. So you have all of the different classification features you can use. So one thing we want to stress is that this is not just for COVID-19 classification. Because the expert labels provide such a wealth of medical knowledge, you can do things like sound quality analysis, detecting whether a cough is wet or dry. You could do medical anomaly detection like wheezing or choking, predicting somebody's age from their cough. I've heard today that you can do that with voice, so why not with coughs as well? So for more information about testing your models, please email us. So in conclusion, we want cough classification of COVID-19 and other conditions to really be a global initiative because this is such a pressing problem worldwide. We want the whole research community involved, and the best way to do that is to have everybody on the same validated data sets. So we contribute our 20,000 plus coughs, many with metadata, 1,000 of which are labeled as COVID-19, and over 2,000 are expert annotated. And then we open source all of our cough pre-processing and detection models, so you don't have to reinvent the wheel on how to clean your crowdsourced databases. Then our expert annotations provide a wealth of medical knowledge, so you can do classification even beyond COVID-19. And then our data set is so diverse that hopefully it'll enable machine learning models to provide generalization to the global population. So here are some quick links to the data set, the pre-processing code, a preprint of our publication, which I recommend you read because it really details how to use the data set and all of the different metadata variables. And then of course, some more information about us. And thank you so much for listening, and I look forward to getting your questions at the Q&A session.